evening, sir, and welcome all the participants. So today is the 67th issue of our INOC DigiConnect webinar, and this has been a landmark in our efforts, and it's our endeavor to continue this. But however, we all want that this pandemic should end, and the number of cases which are now again rising, they are a cause of worry, and that is the reason why we are continuing with our efforts to listen to the leading public health experts and specialists regarding this, what is the situation right now and how we should manage this situation. So our two speakers today is one is our guest speaker, Dr. Chandrakant, Lahariya, who is a medical epidemiologist and health system specialist in India, and who will speak on the COVID-19 vaccination, current status, school opening, and way forward. And our other speaker is our own Dr. Rajiv Kumar Jain, our Senior Vice President. And today we would prefer to hear first from Dr. Rajiv Kumar Jain, what is the current situation in India, so that we have an overall view of what the present situation is locally, regionally, and globally. And then we will ask some specific questions to Dr. Chandrakant Lahariya, who would like to answer our questions. And we all know Dr. Rajiv Kumar Jain, sir, but still I would like to introduce him again to you all, that Dr. Rajiv Kumar Jain is Senior Consultant Health, Indian Railways, and he has got 40 years of experience in health and hospital administration, Fellow Award of Indian Public Health Association, and he has presented more than 145 scientific papers in national and international conferences and journals, and scholarships by WHO, National Institute of Health, USA, Canadian Society for International Health, and International Clinical Epidemiological Network, and International Society for Priorities in the Healthcare. He has been a great resource person for us during this entire COVID pandemic, and may I request all our participants to all our panelists also to, if they can put on their video so that we can interact, and we can have some questions with Dr. Rajiv Jain sir also, because the situation right now is very critical, and everyone is worried because before the second wave also the numbers were almost same, means they were coming down and suddenly they spurted, and we were unable to control the things. So in this regard, may I request Dr. Rajiv Kumar Jain sir to start his presentation, and this particular session is live telecasted on the YouTube also, and it shall be available on our INOC DigiConnect webinar YouTube channel also after this session is over. So Dr. Rajiv Kumar Jain sir.
Thank you, Dr. Sandeep. So here we are again on a Saturday evening, 6:30 p.m. onwards. And again, we are taking a stock of the global, regional, national, and statewide position of COVID-19 epidemiology, because we are living in the real world with a real dynamic situation of the spread of COVID-19 disease, as well as its evolution and the process of vaccination. Let's begin where we have an overview of the global situation on date. So with just over 4.4 million new cases reported this week, that is the last week was 23rd to 29th August, and the number of new cases reported globally remains similar to the previous week after having increased for nearly 2 months. In the past week, all regions of the WHO reported either a decline, that is regions of Africa and the Americas, or a similar trend, that is Europe, Southeast Asia, and Eastern Mediterranean regions in new cases, except for the Western Pacific region, which reported a 7% increase as compared to the previous week. The number of deaths reported globally this week was also similar to last week, with just over 67,000 new deaths reported. The Eastern Mediterranean and Western Pacific regions reported an increase in the number of weekly deaths, that is 9% and 16% respectively, while the Southeast Asia region reported the largest decrease, that is 20%. The numbers of deaths reported in the regions of Africa, Europe, and the Americas was similar to last week. The cumulative number of cases reported globally is now nearly 216 million, and the cumulative number of deaths is just under 4.5 million, which has increased beyond 4.5 million as on date, as I'll show you later. But if you look at the graph down below, you can see clearly the third wave, the third global wave, spreading across the world, but more vigorously now in the Western Pacific region. If you look at the purple colored graph at the bottom, Western Pacific region has the sharpest increase, while it is stable in Europe, and Americas is also stable, and now Southeast Asia region is started contracting. But let's see the data. Let's see the next slide. This is a global scenario. New cases in the last 7 days. Out of 100 cases reported globally, 3% were from Africa, 13% from Western Pacific region, 10% from Eastern Mediterranean region, 14% from Southeast Asia region, and 27% from Europe, and 34% from the Americas. So the largest number of cases reported last week were from Americas, 34%, and Europe, 27%. But if we see the change in new cases in the last 7 days, it is Western Pacific region showing an increase of 7%, even though globally there has been a decrease of 4%. And the largest decrease has been in Americas, that is 9%. Now we look at the death scenario. Out of 100 deaths reported globally, 33 deaths were from Americas, 19 from Europe, 21 from Southeast Asia, 12 from Eastern Mediterranean, 10 from Western Pacific, and 6 from African region. But if we look at the trend, that is change in new deaths in the last 7 days, then we find 9% increase in Eastern Mediterranean region and 16% increase in Western Pacific region. So these two areas, Western Pacific, Eastern Mediterranean, are showing largest increase in deaths. 4% increase in deaths in Europe and 1% increase in deaths in Americas. So at the moment, the epicenter is the Western Pacific region of the World Health Organization, which includes a major country of Australia. Australia is in lockdown at the moment, and it continues to show a huge number of increasing cases and increasing number of deaths. Let's see the trend further. This is the global trend last 7 days. Out of 43,80,000, this is the coronavirus disease dashboard as on date about 1 hour back. Total cases reported in last 7 days were 43,80,000, out of which 16 lakh were from Americas region, 11,53,000 from European region, Southeast Asia region 5,60,000, Eastern Mediterranean region 3,89,000, Western Pacific region 5,48,000, and African region 1,22,000 cases. So you find still Americas, Europe are showing very high number of cases. Let's look at the countries now. The top 10 countries in terms of cases in the last 7 days. This is the absolutely updated figure as on date and time now. Total global cases 43 lakh. United States alone reported 11,22,000 cases. India reported 3 lakh cases. United Kingdom reported 2,34,000 cases. Iran reported 2,22,000. Brazil 1,58,000. Malaysia 1,45,000. Turkey 1,42,000. Japan 1,35,000. Russian Federation 1,31,000. And Philippines 1,21,000. So what do we see? The cases, the top 10 countries are spread across the world, across continents. And look at Turkey, Japan, and Iran. They are small countries, even Malaysia are small countries, but all are reporting more than 1 lakh cases in 7 days. Now we look at the country-wide scenario of deaths. Next slide, please. This is a ranking of the countries in terms of 7 days newly reported deaths in the last 7 days as on date. Out of 66,700 deaths reported globally, 10,000 were reported by United States of America. Russian Federation number 2, 5,500. Mexico number 3, 5,051. Brazil number 4, 4,505. Iran, 4,272. Indonesia, 4,149. India, 3,034. So in terms of death, India has gone down, but it's a temporary reprieve. Vietnam, 2,471. South Africa, 2,088. And Malaysia, 1,980. So again, you find the same figure in terms of deaths. They are across continents, across regions of the WHO. So it's a pandemic evolving from one place to the other, one continent to the other, one region to the other. Let's go deeper now. This is the variants of concern distribution: alpha, beta, gamma, and delta. The top left is alpha, 193 countries, beta, 141 countries, gamma, 91 countries, and look at delta growth, 170 countries which are spread in the world. And India has all the variants: alpha, beta, gamma, and delta. All four are existing in India. And I'll show shortly why this is important. Beta is there in India already. Let's see further. Next slide, please. Based on the latest round of assessments, B1621 was classified as variant of interest on 30th of August 2021, and today is 4th of September. 4 days back, WHO declared the B1621 as a variant of interest and given the WHO label mu. This includes the descendant Tango lineage, that is B16211. This variant is known as 21H in next strain nomenclature. The mu variant has a constellation of mutations that indicate potential properties of immune escape. Please note, it has potential properties of immune escape. What does it mean? People who are vaccinated will still be vulnerable for infection with this variant. Vaccines will not protect against mu variant. Preliminary data presented to the virus evolution working group show a reduction in utilization capacity of convalescent and vaccine sera, similar to that seen for the beta variant. But this needs to be confirmed by further studies. Since its first identification in Colombia in January 2021, there have been few sporadic reports of cases of the mu variant, and some larger outbreaks have been reported from other countries in South America and in Europe. As of 29th of August, over 4,500 sequences, out of which 3,794 sequences of B1621 and 856 sequences of B16211 have been uploaded on the GIS AID portal from 39 countries. Although the global prevalence of mu variant among sequence cases has declined and is currently below 0.1%, the prevalence in Colombia is 39% and Ecuador 13% has consistently increased. The reported prevalence should be interpreted with due consideration of sequencing capacities and timelines of sharing of sequences, both of which vary between countries, so that the real figure may be much, much higher. More studies are required to understand the phenotypic and clinical characteristics of this variant. The epidemiology of mu variant in South America, particularly with the core circulation of the Delta variant, will be monitored for changes. Very important observation. Mu variant, core circulation of Delta variant, and resistance to vaccine. That is immune escape. Next slide, please. This is the overall state of coronavirus variant. The WHO announced on, as I told you, it has designated new variant and mu B1621. And the answer to the three questions are important. Does it spread more rapidly? In its last update on August 6th, Public Health England said it does seem to spread particularly rapidly, and there is no evidence it is outcompeting the Delta variant. Does it defeat past infection immunity? It contains E484K, a spike protein mutation known to resist antibodies. Public Health in England found evidence that antibodies in those with Delta infection may be less effective in neutralizing the mu variant. So the vaccine escape, immune escape is possible. What about vaccines? Due to its genomic similarity to beta, Public Health England believes it can be more resistant. In laboratory tests, it showed antibodies induced by vaccination was less effective, similar to what has been seen in the beta variant. So at the moment, there are 4 variants of concern: alpha, beta, gamma, and delta. Alpha spreads more rapidly than predominant virus. Beta shows significant resistance. Gamma shows some resistance and enhanced infectivity, while delta shows significantly more transmission and somewhat resistant. And the variants of interest are eta, iota, kappa, lambda, and mu. The mu is the latest one. Eta shows maybe more resistant to vaccines. Iota may be more resistant. Kappa may be more resistant and spread more readily. Lambda has several new mutations and found in significant numbers, while mu underwent watch for now how it has grown in several nations like Ecuador. And another positive news is 3 variants of interest have been dropped. These were previously of interest but have since been downgraded: epsilon, zeta, and theta. Right? So this is the current updated position of the coronavirus variants. Now, this is the COVID-19 cases per 1 lakh population reported by countries, a map showing you the real objective data. Look at the countries in brown. They are across the world. You have country in Africa, you have country in Asia, you have countries in Europe, and you have countries in Americas as well. The darkest, where maximum cases per 1 lakh are being reported, the dark brown countries. Next slide, please. This is the map of the world with COVID-19 deaths per 1 lakh population reported by the countries. And I would draw your attention to the dark blue countries and look at the countries. They are again spread all across the world. Asia, Western Pacific, Americas, Africa, and Europe. That is the reality. This is objective data because it has been normalized for population per 1 lakh population, and then the graph has been made. This is the last 7 days. Previous graph was also for last 7 days. So this keeps on changing. Next slide, please. Now we come to Southeast Asia region where India is situated. Southeast Asia region recorded a relatively similar case incidence as compared to the previous week, with over 5,96,000 new cases. Despite a regional decrease in deaths, 3 countries reported increases of over 15% this week. That is Timor-Leste 32%, Sri Lanka 19%, and India 17%. The region reported over 14,000 new deaths, a 20% in decrease compared to the previous week, largely due to 60%, that is 6 out of 10 countries in the region reporting decrease in weekly mortality during the past week. The highest number of new cases were reported from India, that is 2,70,796 cases and 17% increase. Thailand, 1,24,796 new cases with 12% decrease, and Indonesia, 94,375 new cases with 25% decrease. The highest number of new deaths were reported from Indonesia, that is 5,551 new deaths, a 37% decrease. India, 3,463 new deaths with 10% increase, and Thailand, 1,823 new deaths which is similar to the previous week. And look at the graph, overall graph of cases and deaths. Nowhere you find the graph touching the 0x axis or the y axis. Next slide, please. This is the COVID-19 India snapshot for today. Last 24 hours, 42,346 new cases, 340 deaths in the last 24 hours, and last 24 hours, 17 lakh tests were done. 7-day average test positivity rate is still above 2.5%. It is 2.6% at the moment. There are active cases now again touching about 4 lakh, 3.99 lakh at the moment. And they're growing by 1.7%. They're not decreasing. There is no negative now. Total 2.29 crore cases have been reported from India and 4,40,256 deaths reported. 67.5 crore vaccination doses have been given, out of which 51.9 lakhs were given yesterday. Next slide, please. This is the state-wise position and ranking of the states in terms of 6 parameters. That is confirmed cases, deaths, tests per million per day, 7-day average test positivity rate in percentage, and 7-day average daily growth in percentage, and vaccinated persons with at least 1 dose in percentage. So confirmed cases, Kerala reported 29,000 out of 42,000 reported by India. Maharashtra 4,300, Tamil Nadu 1,568, Andhra Pradesh 1,500, Karnataka 1,200, Mizoram 880, Odisha 849, West Bengal 686. So these are the states reporting the top highest 5 states with the highest number of cases. In terms of deaths, the top states are 131 Kerala, Maharashtra 92, Tamil Nadu 19, Karnataka 19, Uttar Pradesh 13, and West Bengal 11. If we, in terms of tests per million per day, Indian average is 1,252, but Rajasthan only 365, West Bengal 443, Madhya Pradesh 800, Chhattisgarh 900, Manipur 980, Haryana 1002. So these are the states which are not conducting enough number of tests so that their data of positivity have to be validated. 7-day average test positivity rate, Indian average is 2.6% at the moment, while Mizoram is having 25.2, and Kerala is having 18.4, and Sikkim is having 9.1, Manipur 9.0, Madhya Pradesh, Meghalaya 8.6.0, Nagaland 3.1. So the states of Northeast and Kerala are still showing very, very high test positivity rates. While Indian average, again, I'll tell you, is 2.6, while Mizoram is 25 and Kerala is 18. If you look at the 7-day average daily growth in percentage, Indian average is 0.13%, Mizoram is having 1.53%, Kerala is having 0.73%, Meghalaya 0.27%, Manipur 2.27%, Sikkim 0.21%. These states are showing extremely high daily growth in terms of 7-day average. Now we look at the states on the right side, vaccinated persons with at least 1 dose in percentage. Indian average is 38.21%, while Bihar 26%, Jharkhand 27.9%, Uttar Pradesh 28%, Nagaland 30%. They are showing much lesser persons or percentage of people vaccinated with at least 1 dose. They need to buckle up. They need to accelerate their vaccination process very, very efficiently and effectively. Now, next slide, please. This is the India's vaccination drive tracking graph. While there has been an increase in pace of daily vaccination, only 1 in 6 adults in India has received both doses of the vaccine. A criterion government has said should be a prerequisite to attend festive gatherings. Vaccination coverage, if you look at, partially vaccinated are 38%, fully vaccinated are 16.5%, and not vaccinated are 45.3%. While 54.7% of India's adults have received vaccine jabs, only 16.5% are fully vaccinated. And you look at the trend, 7-day average is 84,22,000, and new doses are 80,97,000 on September 2. Next slide, please. Now we look at a review of the position of states in terms of healthcare workers and frontline workers having received the first and second dose of the vaccine. If you look at the healthcare workers, the top first dose is by Jharkhand, 93.6. Look at it number. Haryana, 98.5. Gujarat, 100.5. Kerala, 100. Andhra, 99. Himachal, 99. Odisha, 99. But look at the bottom. You have states like Punjab and Madhya Pradesh, and Tamil Nadu 95, Karnataka 85, and Delhi 87, Chhattisgarh 91. These are the states who have not even vaccinated 100% of their healthcare workers with first dose. Leave aside the second dose. If you look at the second dose, there are states like Tamil Nadu, only 59.6% of healthcare workers vaccinated with second dose. Karnataka 67.4% with second dose. Delhi 72.1% second dose. Healthcare workers 73 point in Chhattisgarh, 75.6 in Bihar, Telangana 76.7. So the vaccination for essential category of healthcare workers, which should have been 100% by now, because we started on 16 January, the first dose, all should have received the second dose by now, but it has not happened. If you look at the frontline workers, the situation in Delhi, only 74% of frontline workers have received first dose in Delhi, and only 56.45% of frontline workers have received the second dose. And this is Delhi, the capital of India. And if you look at state like Uttar Pradesh, only 66.5% of frontline workers have received the second dose. And look at Himachal, only 37.5% of frontline workers have received the second dose. And again, Karnataka, only 49% of healthcare workers have received the second dose. So this is something which needs to be looked into. Why, how, and how we can ensure that 100% of healthcare workers and frontline workers receive the second dose, because only through that they will get protection against Delta variant. Next slide, please. Next slide. Well, rural area races ahead as vaccination expands. This is the good news. When India rolled out COVID-19 vaccines, there were concerns that the coverage would be biased towards urban centers with better medical infrastructure. However, data shows that India has managed better coverage in rural districts than in urban ones, albeit with the significant state level variations. Overall, rural districts have received 489 doses per 1,000 population as of Wednesday, as against 451 in urban districts. Next slide, please. Kerala, which leads in the coverage among large states, has given 1,008 doses per 1,000 population in rural districts compared to 827 in urban ones. Jammu Kashmir, Uttarakhand, and West Bengal also have significant surplus in favor of rural districts. The major exceptions are Maharashtra, Manipur, Nagaland, Telangana, where the urban vaccine coverage is at least 1.5 times more than the rural districts. Uttar Pradesh and Andhra Pradesh have an almost equal distribution, while Himachal Pradesh and Rajasthan have only a marginal urban-rural divide, though in favor of the rural sector. Interestingly, many states with a lower population have share in rural districts have done better in providing vaccines in these districts. This analysis considers districts with fewer than 400 persons per square kilometer as rural districts, drawing from the multi-tier 2011 census definition of urban units. Such districts typically have weaker medical infrastructure. This classification may not reflect the actual rural-urban population share. Next slide, please. India has jumped 4 places in vaccination coverage growth. India's vaccination coverage grew 7.8% last week to 663 million, earning it the second slot among the 10 most populous countries in terms of the highest weekly increase in vaccination. It administered a record 12.9 million doses on 30th of August. Other Asian peers, Bangladesh, Indonesia, and Philippines have also ramped up vaccination the past 2 weeks after facing supply constraints in the previous few months. Recent Delta variant outbreaks have strained healthcare facilities in Indonesia and the Philippines. In the Indonesian capital, Jakarta, deaths have been reported 3 times more among the unvaccinated, according to the official data. More than half the population in Jakarta has been vaccinated, but the share is less than 10% in the rural provinces. To aid the drive, Indonesia approved the Sputnik V vaccine for emergency use last week. The Philippines accelerated its vaccination partly with the help of 3 million Moderna vaccines it received from the US earlier in August, the largest ever donation of vaccines by a single country. Next slide, please. The 10 districts with most new cases last week are from Kerala. And Kerala has become the hotspot state. India's top 10 districts with the highest caseload in the last week were all from Kerala, as Onam festivities were followed by a renewed explosion in infection. The state constituted 69% of all new cases in India. In the top 5 districts, Thrissur, Ernakulam, Kozhikode, Malappuram, and Kollam, weekly cases jumped more than 1.5 times, with the biggest jump in Kollam, where infection doubled to 17,937 cases. The other 4 are also the only districts in India to have reported more than 20,000 weekly cases. Maharashtra came a distant second, with a sixth of Kerala's caseload. Cases declined in Northeast, but Mizoram continued to be the state of concern. 6 of its 11 districts witnessed a rise in cases. In Mamit, Lungle, and Champhai districts, cases rose at least 1.8 times. The capital district, Aizawl, continues to register around 3,000 cases. Next slide, please. Kerala has replaced Maharashtra as the state with most deaths. Weekly deaths continue to fall for the 9th week. The toll this week was 3,163, down from 3,317 in the preceding week. In Kerala, the toll increased to 989 from 923, replacing Maharashtra as the state with the highest weekly toll. 2 districts from Kerala, Thrissur and Palakkad, were among the top 5 with most deaths. Maharashtra toll dropped 20% this week to 925. Among districts, Pune saw the most deaths this week, 214, though this number dropped by 28%. Cuttack in Odisha was second, that is 144, where deaths have been on a steady rise since the last week of July, when it had reported just 7 deaths. Punjab also saw a 5-fold rise in toll because of a reconciliation exercise. As the vaccination coverage expands, the number of deaths is expected to come down, even if there were to be third wave. However, the rural-urban divide may need to be addressed. Rural districts are at risk because of weak facilities, and urban areas because of high population density. Both need attention. Next slide, please. Here is the latest evidence from Lancet. Fewer and mild symptoms seen in breakthrough cases is the observation from a study published in Lancet this week. People who tested positive for COVID-19 after 1 or 2 doses of Covishield, Moderna, or Pfizer vaccine has significantly lower odds of severe disease or hospitalization than unvaccinated people, according to a study published in the Lancet Infectious Disease Journal. The large-scale study conducted by King's College London and Harvard Medical School and others showed that after 2 vaccine doses, the odds of hospitalization reduced by more than 2/3, and breakthrough infections were almost 2 times more likely to be completely asymptomatic. The odds of long COVID-19, that is symptoms continuing for 28 days or more after testing positive, also reduced by more than half for people who received 2 vaccine doses found. People most vulnerable to a breakthrough infection after their first vaccine dose included frail older people like 60 years and older adults with underlying conditions such as obesity and diseases of the heart, kidney, and lungs. In all age groups, people living in deprived areas experience a breakthrough infection. Deprivation is a state where people without income and other resources end up in poverty. They are unable to follow COVID-appropriate behavior, their vaccination levels are low, and they cannot maintain social distancing because of cramped living spaces. These factors were most significantly associated with infection after receiving the first vaccine dose and before receiving the second dose. We are at a critical point in the pandemic as we see cases rising worldwide because of the Delta variant. Breakthrough infections are expected and do not diminish the fact that these vaccines are doing exactly what they were designed to do: save lives and prevent serious illness. Other research has shown a mortality rate as high as 27% for hospitalized COVID-19 patients. This is a statement from study co-lead author Dr. Claire Steeves of King's College London, UK. We can greatly reduce that number by keeping people out of the hospital in the first place through the vaccination. Our findings highlight the crucial role vaccines play in larger efforts to prevent COVID-19 cases, which should still include other personal protective measures such as wearing masks, frequent testing, and social distancing. This is what Steve said. Using self-reported data from UK COVID-19 symptom study, through the ZOE app, ZOE application, which is a COVID-19 epidemiological research mobile application. From 8 December 2020 through 4th July 2021, researchers found that of more than 1.2 million adults who received at least one dose of either Pfizer-BioNTech, Oxford AstraZeneca, also known as Covishield in India, and Moderna vaccines, fewer than 0.5% reported a breakthrough infection. That is 6,030 positive cases out of 12,40,000 first vaccine doses, which is more than 14 days after their first dose. Among adults who received 2 vaccine doses, fewer than 0.2% experienced a breakthrough infection. 2,370 positive cases after 99,71,504 second vaccine doses, more than 7 days after their second dose. Among those who did experience a breakthrough infection, the odds of that infection being asymptomatic increased by 63% after one vaccine dose and by 94% after the second dose. Researchers also found that the odds of hospitalization were reduced by approximately 70% after 1 or 2 doses, and that odds of experiencing severe disease, defined as having 5 or more symptoms in the first week of illness, were reduced by approximately 1/3. In addition, the odds of long COVID were reduced by 50% after 2 doses. Very important evidence that vaccines are working. Vaccines are doing what they're supposed to do. Next slide, please. A reduction in the arrival of patients from other states due to lockdown could explain undercount factor falling below 1 in 2020. This is another evidence coming from Delhi, where the number of excess deaths registered by the civil registration system in Delhi ever since the COVID-19 pandemic hit, that is from April 20 to June 21, was an estimated 55,239, which is 2.2 times the official reported figure of 24,977 COVID-19 deaths for the same period. The undercount factor increased to 3.4 if only January to June 21 period is considered, rising due to a surge in mortality during second wave in May and June 2021. Next slide will show you the data as per year. Next, this is the slide. First, April, December 20, January, May 21, January, June 21, and April 20 to May 21, and April 20 to June 21. The multiple factor 2.2 from April 20 to June 21. But if we look at January, June 21, multiple factor is 3.4. And look at the graph. The figures in the black are of 21 deaths, in 2021 deaths, in red are 2020 deaths, and in gray are 2018 and 2019 year deaths. And you can imagine the number of deaths that occurred. So 2.2 is the factor which is visible now. I would now like you to listen to the Health Secretary in answer to a question in the press conference held 2 days back. This is an important conversation, and this is an important information which all of us should be aware and should listen to him in response to a question.
Sir, we can take some questions now. Number 2.
सर नितेंदु डीडी न्यूज से साउथ अफ्रीका में एक म्यूटेशन हुआ है, नए वायरस का पता चला है, म्यूटेट वायरस का, उसके प्रसार कई कंट्री में हुआ है। तो भारत सरकार क्या कदम उठा रही है ताकि देश के अंदर वो म्यूटेशन वाले वायरस ना आ सके, इसके लिए क्या कदम उठाया गया?
इस प्रश्न के 2 हिस्से हैं। एक हिस्से का उत्तर तो मैं दे देता हूँ, इंटरनेशनल ट्रैवल के दृष्टिकोण से हम क्या कर रहे हैं। दूसरा हिस्सा साइंस का है कि कोई भी जब म्यूटेशन होता है तो भारत सरकार की क्या व्यवस्था है, वो डॉक्टर पॉल और डॉक्टर भार्गव देना चाहेंगे। आप लोगों को याद होगा कि फरवरी 2021 में पहली बार हमने बहुत ही विस्तार से गाइडलाइंस जारी की थी कि जो विदेशों से भारत की यात्रा कर रहे लोग हैं तो उनके साथ किस प्रकार की टेस्टिंग और किस प्रकार का प्रोटोकॉल फॉलो किया जाएगा। तो ये जो फरवरी 2021 की चिट्ठी थी जिसको हमने राज्यों के साथ शेयर किया और वहाँ फिर ट्रेनिंग हुई, क्योंकि जो भी अंतर्राष्ट्रीय हवाई अड्डे हैं वो विभिन्न राज्यों में हैं, तो उसमें देशों को दो कैटेगरीज में बांटा गया था। एक कैटेगरी में थे यूनाइटेड किंगडम और यूरोप और मिडल ईस्ट। इस कैटेगरी के देशों से आने वाले यात्रियों के लिए हमने ये कहा था कि चलने से पहले, बिफोर एम्बार्किंग ऑन द फ्लाइट, उनके पास RT-PCR नेगेटिव टेस्ट रिपोर्ट होनी चाहिए, और जब वो हमारे देश के किसी भी हवाई अड्डे पर उतरेंगे तो फिर से उनको एक RT-PCR टेस्ट कराना होगा, सैंपल देना होगा। सैंपल देने के बाद वो अपने अपने निवास स्थान पर जा सकते हैं, और सैंपल का रिज़ल्ट जब आ जाता है तो उसके आधार पर यदि वो पॉजिटिव पाए जाते हैं तो जो भी फॉलोअप कार्रवाई हमें करनी होगी वो हम करेंगे। वो आइसोलेशन, क्वारंटाइन या हॉस्पिटलाइजेशन से संबंधित हो सकती है। अन्य देशों के जो ट्रैवलर्स थे, इन 3 कैटेगरीज को छोड़कर, उनके लिए हमने कहा था कि जहाज़ में चढ़ने से पहले, बिफोर एम्बार्किंग ऑन द फ्लाइट, they must have a RT-PCR test, and once they touch down and disembark at an international airport in India, then they need not be subjected to any RT-PCR test, they can straight away go home. अभी हमने 31 अगस्त को इस आदेश में संशोधन करके इसका जो पार्ट बी था, जिसमें कि यूके, यूरोप और मिडल ईस्ट शामिल थे, उसमें कुछ और देश शामिल किए हैं। ये देश हैं साउथ अफ्रीका, बांग्लादेश, बोत्सवाना, चाइना, मॉरिशस, न्यूजीलैंड और जिम्बाब्वे। यानी अब यूनाइटेड किंगडम, यूरोप, मिडल ईस्ट, साउथ अफ्रीका, बांग्लादेश, बोत्सवाना, चाइना, मॉरिशस, न्यूजीलैंड और जिम्बाब्वे से आने वाले अंतर्राष्ट्रीय ट्रैवलर्स को न केवल नेगेटिव RT-PCR टेस्ट करवा के ही फ्लाइट पर चढ़ना होगा, बल्कि भारत में आने के बाद हवाई अड्डे पर उन्हें फिर से RT-PCR टेस्ट कराने होंगे, और उसके रिज़ल्ट के आधार पर हमें जो भी क्वारंटाइन, आइसोलेशन, हॉस्पिटलाइजेशन की कार्रवाई करनी होगी वो हम करने के लिए स्वतंत्र होंगे। इसकी जानकारी सभी राज्यों को दे दी गई है, क्योंकि ये 31 अगस्त को आदेश निकाला गया था, और राज्यों में जो हवाई अड्डे हैं वहाँ जो हमारे इंटरनेशनल एयरपोर्ट हेल्थ ऑफिस होते हैं उनको भी ये जानकारी दे दी गई है, और ये प्रक्रिया अब प्रभावी हो गई है, लागू हो गई है। और इसको ये जो नए म्यूटेंट जानकारी में आ रहे हैं उसके कॉन्टेक्स्ट में किया गया है। अब म्यूटेंट्स की ट्रेसिंग, उनकी जीनोम सीक्वेंसिंग और उस जीनोम सीक्वेंसिंग के आधार पर किस प्रकार के पब्लिक हेल्थ एक्शन लिए जाने चाहिए, उस पर डॉक्टर पॉल और डॉक्टर भार्गव कुछ प्रकाश डालना चाहेंगे।
आपका जो सवाल था, ये जो म्यूटेंट के बारे में जो साउथ अमेरिका में कोलंबिया में पाया गया है, तो इसमें यह है कि कोलंबिया की आबादी तो बहुत ज़्यादा नहीं है, 5 करोड़ के करीब आबादी है, मगर ये म्यूटेंट वेरिएंट ऑफ इंटरेस्ट अभी कहा गया है, और इसको क्लोजली ऑब्ज़र्व किया जा रहा है, और WHO भी क्लोजली ऑब्ज़र्व कर रहा है, और इसमें ऐसा अभी नहीं देखा गया कि सीरियस डिजीज़ हो रही है या रैपिड स्प्रेड हो रहा है, मगर समय बताएगा थोड़ा सा, इसमें अभी कुछ कहना मुश्किल है। जैसे ही पता चलेगा आप लोग को बिल्कुल बताया जाएगा उसके बाद।
इसमें ये बात कहना चाहेंगे कि म्यूटेंट्स का रिस्क रहेगा आगे तक। म्यूटेंट्स जो भी हों, जो टूल्स हैं हमारे पास टेस्टिंग का, ट्रैकिंग का, टीका का, क्लिनिकल प्रिपेयर्डनेस, हॉस्पिटल प्रिपेयर्डनेस का और कोविड से बचने के बिहेवियर का, ये टूल्स हमारे हाथों में हैं, और इनको दृढ़ निश्चय से पूरी तरह से हमें इस्तेमाल करना है हर म्यूटेंट के लिए। साथ साथ हमारी जिम्मेवारी ये रहती है कि उस म्यूटेंट के जो नेचर है, बिहेवियर है, असर है पब्लिक हेल्थ के ऊपर, चाहे सेवेरिटी ऑफ डिजीज़ की बात है, चाहे ट्रांसमिसिबिलिटी की बात है, या वैक्सीन के ऊपर कोई असर पड़ता है, ये हम सिस्टमेटिकली समझें, और अपनी लेबॉरेटरीज़ में अपने डेटा के ऊपर हम उसके ऊपर सजग हों, उसके बारे में आपको मालूम है कि इंसाकॉग इनिशिएटिव के द्वारा 270 के लगभग सेंटिनल साइट्स हैं, 30 के ऊपर लेबॉरेटरीज हैं, ह्यूज कैपेसिटी है। तो वो कार्यक्रम बहुत सुदृढ़ हुआ है विद टाइम, और वो काफ़ी हमारे पास वो रडार स्क्रीन की तरह एक पूरी नज़र रखी हुई है, और उसको हम इस्तेमाल करते हुए इस एस्पेक्ट को लुक आफ्टर करेंगे। स्पेसिफिकली एंड मैं कहूँगा कि जो इंटरनेशनल ट्रैवलर्स की जो स्क्रीनिंग है जेनेटिक सीक्वेंसिंग के पॉइंट ऑफ व्यू से, जेनेटिक सीक्वेंस रिलेटेड सर्वेलेंस के पॉइंट ऑफ व्यू से, वो that is one of the most critical element and protocol and pillar of our approach through INSACOG.
Number 70.
So you have to unmute us.
I must thank you all for the patient listening and for today's episode of COVID-19 updates. I think that is all I want to share with our audience. Thank you so much.
Thank you, Dr. Rajiv Jain. This was a overall broad view of what is the current status of COVID-19 pandemic. So we are still in a very critical stage, and yes, as Secretary and Secretary Health and other senior colleagues also, they told that the whatever tools we have right now in our hands, we should continue with them, and mutations will definitely be there, and with increased transmission, mutations will further increase. So we have to live with the virus. That is the message which this particular EPID update it gives. Now, how to live with this virus and how to take new initiatives about our children, about opening of the schools, about vaccines and other things. Our next guest speaker is Dr. Chandrakant Lahariya. Dr. Chandrakant Lahariya, sir, he is a senior public health expert, and he did his MBBS from Delhi only, from Maulana Azad Medical College. He has been associated with a number of primary health reforms in Indian states, and he is widely known and highly respected expert of vaccines introduction and routine immunization strengthening. And between 2008 and 2011, he worked to establish institutional mechanisms for new vaccines introduction in Indian immunization and immunization program. And Dr. Chandrakant has published more than 200 articles in reputed national and international journals. And he is the youngest fellow ever elected to Indian Public Health Association, and received Government of India, Indian Council of Medical Research, B.C. Srivastava Foundation Award for translating community-based research, public policy, year 2012. And he is co-author of the book titled Till We Win, India's Fight Against COVID-19 Pandemic, with Dr. Gagandeep Kang and Dr. Randeep Guleria. So Dr. Chandrakant, sir, we will have a good interactive session with you. And as we had been discussing that vaccines, yes, they are very important. And despite the people who have taken vaccines long back, some breakthrough infections are happening, but they are the only tools available right now to decrease the severity of infection and to keep the people safe. And another important point is, as in your last session with us, what you have told us that children health is very important. Their psychological, mental development, that is also very important. And every loss of 1 year in their curriculum, that will give a double impact on their mental health and their physical health also. So getting kids back to the school, it is a national priority for every one of us. And now states, they have also taken now initiatives to start the schools, and the children, they are getting going to the school, although not compulsory, but in a hybrid mode. So the scientific evidence to date about COVID-19, they tell us that kids, they are less likely to get infected than adults, and they are less likely to suffer severe effects even if they are infected, and they are less likely to transmit to others, particularly for 0 to 9 years of old children, because their immunity is very strong. So returning to school by the children, what all precautions we need to take, what are your guidelines for them, how the parents should take care, and so that even if the children they go to the school, they don't come back with infection and infect the elderly people. So Dr. Chandrakant Lahariya, sir, the floor is yours. You can start your deliberations. After your session, we will have questions, sir, both for Dr. Rajiv Kumar Jain, sir, and for yourselves.
Thank you very much, Dr. Sharma, and it's always pleasure to speak after Dr. Jain, Rajiv Jain, because he covers a number of aspects, so it's always easy to build on that. Also, what I'll do, I'll try to build upon the last conversation, and as you highlighted, mainly focus upon vaccines, but also weave around opening of the schools and everything in that context. Coming to the vaccines, we know India has approved 6 vaccines have been given emergency use authorization. 3 are already being used, and 2 may or may not be used, Moderna and J&J, because they require, they have asked for granting indemnity, which essentially means they should not be legally bound to pay compensation in India, and government has not decided. So we don't know what would be the future of those vaccines. And Jacob-D, the Zydus Cadila vaccine, has been approved for 12 to 17 years as well, along with the adult population. We expect that vaccine would be, some shots would be available starting mid of October. So that will be 4th vaccine to be rolled out. But we also know that Sputnik V supply is really limited in India. So majority of vaccination is happening through either Covishield or Covaxin. Covishield around 87% and Covaxin remaining. Contribution of Sputnik is less than 1%. Now coming to the breakthrough infection, we have learned over a period of time, and there are a number of studies which have emerged from different parts of the world, that all of these vaccines reduce from moderate to severe illness and mortality. The people who have received vaccine is less likely to, even if they can get infection, but likelihood of developing moderate to severe illness is very low, and even the mortality is very low, like people do not require hospitalization. So breakthrough infection do happen. We know that efficacy of vaccines are around 80%. So there would be a small fraction of people who might still be unprotected and develop infection. But if people are vaccinated, the severity is less. So that's a really assuring part. Vaccines do not prevent from infection, but they do provide a benefit in other sense. How much is a breakthrough infection? Like even the majority of those studies have been done on hospital staff or health workers. It has been found like upper bound is around 10% of the people had faced a breakthrough infection, which appears a big number, but we need to remember that the amount of exposure or the duration of exposure is really high. So 10% is not that big, and all those who develop infection do not require hospitalization. Majority of them do not require hospitalization. So we should not be worried about breakthrough infection that much. Of course, that is another reminder that everybody who is vaccinated need to wear masks, but health workers and other staff need to be more careful because of level of exposure. So that's on vaccines. India has also now licensed a vaccine authorized, emergency use authorized for 12 to 17 years, Jacob-D. Now, this has generated a lot of interest in the people. People are actually proactively waiting for that and once this vaccine is available, then children can go to school. But that's a wrong assumption. Nowhere in the world children younger than 12 are being vaccinated and schools are open. 12 to 17 years are also being vaccinated in some countries, not all countries. And some of the countries which really give a good consideration to scientific evidence, as an example, United Kingdom, the vaccines for adolescents 12 to 17 years are not recommended for everyone. They are recommended only for high risk population. So only yesterday, UK Joint Committee on Vaccination recommended that all children in the age of 12 to 15 do not require vaccination. Only selected identified group of children require vaccine. And this is very important from the perspective that in India there is a lot of demand and a lot of eagerness that all children need vaccine, though policymakers are not saying that. So we should be careful about that. UK is going to vaccinate a small fraction of population, and we need to remember that UK is not in the situation which India is. UK has licensed vaccines and assured supply. So they are not deciding based upon supply or licensing or availability. They have everything assured. Their adult population is fairly high coverage. So if they want, they can do, but they are deciding based upon scientific evidence. That's why UK not vaccinating all children in 12 to 17 years. Now in India, the vaccine has been licensed. We are hearing policymakers that in the beginning will be most likely for for high risk population, but there are operational challenges also, because operational reality also, let's say in 12 to 17 years, India has around 15 crore children. Now currently licensed vaccine Jacob D is 3-shot vaccine. So to vaccinate 15 crore children, if assume that all children need to be vaccinated, then we require 45 crore shots. However, the production capacity of Jacob D is going to be around 1 crore in the beginning, shots in a month. And the optimistic estimate is that by end of December, they can produce around 4 to 5 crore, which essentially means around 1.4 crore to 1.7 crore children can be vaccinated with that many shots. So this is not really an option that children can be vaccinated. We should, if we start thinking that all children need to be vaccinated before schools can be started, that's a wrong assumption. That's not scientifically valid. We heard some of the leading expert talking about still arguing that children need to be vaccinated before schools can be opened. But I am more inclined toward what Dr. Randeep Guleria, director of AIMS, said day before yesterday. He said that the vaccination of targeted children may take 9 or more months, and schools should not wait for vaccinating children. And that's a global evidence. So schools can be opened without vaccination. That's the first message. Now, there is a lot of debate and discourse around that whether schools should be open or whether vaccination is required. In my opinion, the question is not whether or not. Question is how and when. Schools should be open because schools are open across the world. More than 185 countries have their schools open in one or other form. Now, India is also starting in select states. But whenever people are opposing school opening, some of them are parents association, which is like we are not sure whether those are really informed or ill-informed about this thing requirements. Why they are opposing, because 70% of the parents whose children study in government schools want school to be open, and for them school should be open definitely. Some of the upper income, high income group schools or private schools, because in those schools majority of the parents decide the school policy, may not open, but that there had to be differential approach, that those schools which can be open where parents are demanding should be open, but in scientific evidence all schools should be open. So one of the requirement which people say that, oh well, vaccine should be available, then school should be open. And then second argument which people give, that in the United States the number of new infections are emerging and children are getting affected. Now that is an incomplete argument, but more importantly, even when we are hearing that United States has an increased number of children getting infected, what is the reality? That schools are open in United States. They themselves have not closed the schools for that reason, which we are arguing that schools should be closed in India. So US schools have been open for most of the time, even at the peak of all the previous waves and even now. So that's one. Second part is that US data is used misleadingly. One is that we are at the stage of pandemic where infection alone is not the concern. The key concern is that what happens if person get infection, and then what is the outcome. So whether an infected individual will develop moderate to severe illness and disease or mortality. So that the outcome is severe in adult population, but the outcome of infection is mild in children. And that's a key difference. That's one point we need to remember, that children do get infected at the same rate as adults, but outcome is not severe. And that's why schools should be open. And that's why it's considered that children are relatively safe and schools can be safely opened. Other reason is that there is evidence that schools do not work as a super spreading places. So we should not worry. Third part is that often the numbers of United States is depicted that this 100,000 children got infected, other children. What is not usually shared in the media, that though infections are widely reported because United States tests really high, but the number of hospitalization even in US remained really low in children. So then some people use data, and I was on another program this afternoon. Somebody was saying, yeah, well, infection, hospitalization in children has increased by 400%. Now, this may appear scary, but that's an incorrect interpretation. Why is incorrect interpretation? That the total hospitalization in the children of the, or hospitalization in children of the total hospitalization is around 0.003% to 0.2%, 0.0032 to 0.2%. So hospitalization as a share of total hospitalization is really low in children. So even a minor increase would mean like it's a 300-400% if we use percentage in that approach. But if you look at the proportion would have changed only from 0.003 to maybe 0.2% or from 0.2 to 0.8%. So still proportion of hospitalization in the children remain less than 1%. Children are really low risk, and the deaths are really rare in the children. And that's why school should be open. Third part, the key difference in United States and India is that in US, especially, we hear a lot about Florida and other states. In US, people are proactively opposing mask wearing. Like people are not wearing masks even after this thing. And that's why there are a high rate of infection in all age groups, but there is a hospitalization in non-vaccinated adults, but children are relatively safe. Final key difference which we need to differentiate from US and India is that India has already faced Delta variant, which is affecting US. And we know that US did vaccination first, and now Delta is coming up, hitting them now. So then vaccine work very differently. But in India, the Delta is already crossed. And we know that once a variant affect a population, it is very unlikely to affect very quick succession in India. So India is relatively safe. Final part is that what we need to remember that India already has 60% of children developing seropositivity or developing antibody, which essentially mean they had a infection when they were staying at home, and then adults had a very even higher level of antibody, and now adults are being vaccinated. So the proposed relative protection in India is fairly high. Now, some people argue that third wave would affect children severely. There are many arguments that third wave would not affect children severely, but the biggest argument is that 60% of the population is already has antibodies, so the susceptible population is 40%. So susceptible pool is far smaller than it was earlier. So even if there is no possibility theoretically, and especially knowing that Delta variant would not affect twice in the quick succession, there is no possibility that impact on children could be bigger than the previous wave. So with all of these factors, there is no rationale that children would be severely affected. Children do not need as a requirement for opening school vaccines. Children may need vaccine in the time ahead, because in the end, when infection or all other age group will come down, the benefit of vaccinating children is currently less in comparison to adults. But we can also hope that with the time there would be a better vaccines, maybe a nasal vaccine, which will help in reducing transmission. And those kind of vaccines can be used. Now, coming to the schools part, schools can be safely open. They are open in 180 countries. There are studies which have found that they do not increase risk. Of course, what should be done to open schools? I believe that this has to be a dialogue. Dialogue means whenever, because one part is that because people have experienced, all of us have seen really severe second wave. Somebody known or somebody distant family either got affected or some other adverse outcomes were there. So people are really scared. But what is happening that people are mixing two things, because this is about children. The adverse outcome in second wave was in mostly in adults. Like all of us might have heard that somebody we knew died, but there would be very few in this group who would be knowing a child died due to COVID-19. Children passing away is very rare, and children developing severe infection is rare. So, but what people are doing, people say, oh, well, severe wave was second for adults, but then if it was second for severe for adults, then why we are punishing children for not going to school? Children are not at risk. More importantly, if an adult member of family is going out for the work or any activity and then coming back to the home, he or she is bringing infection to the child, and that's how children have got infected. In comparison of that, and after that, if any member is going out, sending child to school does not increase risk. In fact, risk is far greater at the malls, public place, markets, in the schools, because children are widely protected, they are safe, they do not develop infection, so the risk is not high. Yes, there could be some group of children who may not be right candidate to go to school immediately. One is that if children have a pre-existing comorbidity, then they should continue with the home schooling or online learning. But comorbidity in children is considered around 1%. The worst, like if we take an even wider sense, up to 5% could qualify for comorbidity. By that logic, essentially 95% of children can go to school safely. Then there could be second group of families from which children cannot or should not go to school, which could be there is a elderly member, unvaccinated, or immunocompromised member, or some long-term illness. If there is such member, children can bring infection back home and they could be high risk. But majority of the families which are nuclear in urban setting, husband, wife, healthy adult, and even comorbidity but vaccinated. So majority of family, like 70 to 80% or even 90% of the family would fall into that subgroup from which children can go to school. So either way, we look from child's perspective or family's perspective, majority of family can send their children to the school. What school should do to make arrival or teaching of the children safe? The key requirement is ventilation. So we need to remember that to make schools safe, the ventilation in school need to be improved. The window and doors should be open, putting a fan. So there can be some measures done. Second is a vaccination of all the staff working in the school should be facilitated. Third is a mask. Now, these three are core requirement. Above that, hand washing, sanitization are useful, but we now know that the role of fomite or object-based transmission in virus transmission, a role of fomite in virus transmission is very limited. Like we were cleaning our hand and so finicky about putting things outside in the sun in the beginning of the pandemic and all this thing. But we know we don't have any evidence that the food delivery or parcel delivery or any touch to the surface results to the transmission of virus. So while we should be paying attention on the cleaning and all those as a precaution, but in the schools or any setup, we should not be too finicky that a child touch the tiffin box of another child or child touch the books of other child or touch the surface. Those are unlikely to cause transmission. And we know children are already infected, like they are very much similar rate of infection as adults without severe illness, so schools can be open. Of course, what need to be done that school opening had to be a voluntary process, like for schools, but also for parents, it should not be mandatory to send children to the school. Somebody who want to continue the online learning, they should continue, though there is disadvantage, there is loss of learning. But those parents who are willing to keep retain online learning probably are the one who can afford some additional provision for children, such as they can teach their child at home, they can arrange additional classes. But schools should be opened for majority of those poorest, lower middle income families who have no option, and there is no risk to those children, especially those playing in the lanes of the urban slums or even colonies playing with each other, and the rural area children are playing with each other, doing everything except schools are opening. So there is a very low, almost negligible health risk to children, but the benefit of education is far higher. I have written extensively about benefit of education. We know that education is not merely about what is taught in the books or taught through the books or what is taught by the teachers to the student. It's more about social, physical, mental, emotional development. When children interact with each other, they learn communication skills. When children work with other children, they learn skills, how to negotiate, how to stand up when they fall, and all of those. The real life learning schools happens in schools and colleges and interactions. We put too much importance on what is taught through the books, but we know there are people who are not that well or good in the scoring marks, but they have a good life skills, and much of those come through real life interaction. Currently, the real life interaction is not happening due to COVID, and even if we deprive them of schooling, this is a real loss of many important years in the life of children, and especially for the primary school. I have argued in one of the piece I published recently in the Asian Age, where I have argued why primary school should be first to start. There are many arguments, but I would like to highlight two arguments. One is that while older children who have learned alphabets and numbers and who can read and write can still attend online classes. They can attend online classes because they are also allowed longer screen time, the time they can spend in front of mobile or computer. So they can learn because they know things. But younger children, especially those in first standard, second standard, they are about to start learning. They don't know alphabets, numeracy, number skills. For them, the personalized learning is very important. They cannot be taught on mobile or online teaching. They also important that for younger children, the screen allowed time in front of screen, the screen time is really low, so they cannot have a longer classes. So all of those losses are happening. And especially for the poorest of the children, the biggest loss is happening that many of those children attend a government school where midday meals used to be provided. So it was not merely about learning or education for them, it was about nutrition of those children also. Though some of the states have continued with the dry ration being given to the family, but we know it's not the same. So it's not the loss of education only, it's a nutritional loss or health loss also for children. So there are many arguments why all of children should go to school, but primary school children should go to school first. And the final point in all of this, and then I'll stop for the questions, is that why all of the children are safe, and there is a various data which is being analyzed and available. So there is the moderate to severe illness and mortality in all age groups follow English alphabet J-shaped curve, which essentially means if you imagine J, so the base of the J is the 10-year-old child. So 10-year-old child has the lowest risk in any age group of moderate to severe illness and mortality. So they are the safest. Then the risk increase in the both direction, the short arm of J and the long arm of J, both direction. So it increases to the 9-year-old is slightly higher risk than 10-year-old, 8-year-old is slightly higher risk than 9 years, 7 years slightly higher than 8 years, till newborn. So risk increase, but risk remain very, very low, but increase proportionally. And similarly, the risk increase from 11-year onward, 11, 12, 15, 17, 45, 60, 75, 85, whatever age we go upward, the risk increase. So the risk is lowest for the children, all children, they are base of the J, but within the children, the risk is least for a 6 year to 14 years. And these are the children who are in primary or upper primary. So that's why the children who are the lowest risk are at the worst disadvantage. Because schools are open for older children, schools are not open for the children who are at the lowest risk. That's why primary schools should be open first. In many countries, primary schools are open. In fact, some of the countries, United Kingdom and other countries, do not recommend that kind of major restriction, like masks for younger than 12 are optional, especially in schools and all those. They are not actually required. The physical distancing in children is optional, because we are already saying that children are not risk of severe disease. So anything which is done over and above is a add-on. So masks are add-on, physical distancing is add-on, vaccination is add-on. Children are really low risk and they can safely go to school. And the biggest evidence is that many other countries which have their schools open for longer period. In fact, Sweden is an example which never closed anything. They did not even have a lockdown, and outcome of lockdown was not very good. They had a higher mortality in adults in comparison of other Scandinavian countries. But when it comes to children, there was no difference in the outcome. Like for a particular period, Sweden, in spite of everything being open, including schools not being closed, even for a single day, they had not reported, as far as I know from the data, even a single death in the children. So children are really protected. That was a kind of not a good example, but through that example, we know that children are safe and they are safer than any other population. So those should be open. I think I'll stop here and then maybe we will have a dialogue around questions answer. Thank you very much.
Thank you, Dr. Chandrakant sir. We have given a very pointed guidelines for opening up of the schools and about the vaccine status. We'll summarize it later on, but the only question to me is you have already answered, but additional point what is important for me to say is are the number of cases in the areas where the number of cases are very high. So should we open the schools in these areas? Or
Yeah,
we have to
okay.
take a call?
No, I think nobody should say that the school should be open in all settings. For example, Kerala has having a different kind of transmission. School should not be open there. But similarly, in Maharashtra, also schools can be open, in my opinion, majority of the places. But the approach has to be very differential. Differential means that state can decide a cutoff, say less than 5% test positivity rate could be a good idea. What we need to remember that globally, the recommendation is that schools should be first to open and last to close. And it could be a very different, it could be, there could be many other approaches in addition to test positivity rate. Some experts say that it should be linked to the outpatient department of a major hospital or district hospital in that city. As long as the outpatient department is open, the schools should be open. But I think that is a little too much of stretch, but the approach could be very similar. That if you are opening up any market or if you are opening up malls, schools can be linked to that. Whenever mall markets will be open, school can be open. So those kind of, so there can be multiple approaches. But what we need to remember, this could be a broad guideline, but it can be have an additional layer. For example, rural schools can be opened very fairly quickly and easily, because rural areas fairly independent, children are talking to each other, interacting. Similarly, the government schools with the new midday meal can be opened easily because parents are more willing to send. Ultimately, school opening is two part. One, school should be open. Second, parents should be willing to send. In some of the private hospital, big private schools, parents are not willing to send children, and they should not be coerced. I agree on that. So they might be open little later on. So approach should be differential, dynamic. So criteria can be decided. A government is free to decide. For example, Uttar Pradesh did a right thing, that if they are having a low cases, they have opened primary school for across the state. Punjab opened from all the schools from second week of August or first week of August. So school can be differentially open. Even in Delhi, if Delhi is reporting 25 cases in a day, there is no reason that all the schools should be closed. We cannot be keep schools closed for something which is uncertain, while the loss of education is real certain. Other thing is that school opening is going to be a process. When schools will be open, they will take some time to prepare themselves to get children. They will adjust to the new reality. So it's not that if we say tomorrow schools are open and everything will be ready. So we should give schools time. School opening means schools getting ready, then children will start coming to schools, and finally school opening does not mean that they cannot be closed. So if the cases rise and there are some challenges, schools can also be shut down. So in my opinion, Criteria can be determined locally. It would be different for different states. Rural area probably can do far safely than urban setting, and urban setting government school can do little better. Even within a state, different district can follow different approaches. It had to be dynamic, cases rise, it can be closed. But final part I also want to bring that we should not be finicky, or parents should not be finicky that if in the school, because of opening a school, some child is tested positive. It is very much likely due to different reason, and even if a testing positive does not mean anything, infection is not serious concern. What is should be our concern, that what is going to be outcome of infection. And now India or world is at the stage of pandemic where transmission is happening. Every single infection is not a concern. What might happen due to infection, that is a key concern, and that is a concern for adults. I often say that this is a serious disease for adults. So if anybody should stay at home, adults should stay at home. The unvaccinated adults should stay at home. It is just because adults are making decision for children, they want to keep their schools closed. If we want to really act like adults, we should open schools.
Any take on the transportation of the students to the schools, to and fro from the schools?
Well, so that is a major concern for parents, and understandably. But as I highlighted and reflected about that point, that the fomite transmission, role of fomite transmission is really limited. We don't really know, like, and we have not heard that people got infection through touching surface or office table or food delivery. Those are not there. In the transportation, the air conditioned buses could be a risk. So probably those should be avoided. Windows should be open. The number of seats should be restricted. Number of children in the bus should be restricted to number of seats available in the bus. Masking should be done. Those can be fairly done well, but of course that's a key concern of the parents, because children will interact and they will be sitting too close. We cannot have an answer a priori, but there is no evidence that bus transport can result in increased risk of this thing. So it's a concern amongst parents, but no evidence, no reason to believe that it will cause any major issue. But I would not recommend, and evidence points that we should have a non-air conditioned bus is better. And right now, at least now, weather is that can be done. So non-air conditioned buses would be fairly safe.
Dr. Sandeep, I would like to supplement what Dr. Chandrakant has mentioned.
Yes.
As you know, we are living in a very differential world. Like even in Delhi, there are schools and there are schools. We have one of the most elite schools in Delhi, and we're the most deprived schools also in Delhi. As you know, in Delhi, all the primary schools are managed not by Director of Education, but by the Municipal Corporation of Delhi. All the government primary schools. So there is a different level of decision making, and there are two opposing parties to decide. But if you look at the elite schools, what I have seen now, because my wife is teaching in one of the most elite schools, the Air Force School in Dholakua, and I find on online classes, most of the students of class 11 and class 12, they preferred to be taught online. I found none of the students consenting to go offline and go physically to school. I'm not talking the parents. I myself heard all the students without exception of class 11 and 12 refusing for offline classes in the school. They preferred to go for online classes. As Dr. Chandrakant very rightly mentioned, their retention and their the confidence level that they have gained during the pandemic through online classes is tremendous, I find, because of the ease of comfort. And these are elite schools, meaning all these students have a very good wavelength of bandwidth. They have good devices at home, and they prefer to be taught online. So, and that reflects the global scenario. But on the other hand, the government schools do not have the luxury of the students having access to devices and the internet bandwidth. So naturally, the parents as well as children would prefer to go to the schools. And that is exactly what has happened for government schools. So the behavior and the response has to be differential. You cannot have same yardstick for all. Second issue which Dr. Chandrakant very rightly mentioned, and Government of India has been spreading this message through, decision making has to go to the district level and below. And sub-district I would focus as the best level, that is the block level for decision making for school opening or closing. So for that you require a good testing infrastructure and good data collation and interpretation ability. That surveillance integration and that skill. Fortunately, through this 20 months of pandemic, a great capacity building has occurred at the sub-district, that is the block level in India. And very good states, we thought that they are backward states, are very forward-looking now. I was surprised to find Jharkhand having vaccinated a substantial number of healthcare workers and frontline workers. And also I find their response was more, I would say, appropriate to the data on the ground. Similarly, I found response in Uttar Pradesh, as Dr. Chandrakant was very rightly mentioning, the rural schools, primary schools especially, remain open. You need this kind of decision making, which is based on evidence. Now that evidence-based decision making at the district level and the sub-district level is the real need of the hour, because this is going to be a very dynamic situation. That capacity of the block administration and the district administration to take decisions based on evidence that they have. They have their own evidence and they take their decision and own their decision. That is the best option for the country at the moment.
Yeah, that's what Dr. Chandrakant told me. Whenever you are opening the malls or the markets, that should be linked with the school openings also. So if the number of cases are rising, you are closing the malls, then you should close the schools also. If you are so linking it with, we should not keep the schools separate. And some decisions shall be made at center level. We should not wait for all these decisions. And rightly said, so we should decentralize this school opening to the district level or up to the block level. Let them decide. And as primary school, government schools where midday meals and other things, they are of great concern. That nutrition part is also a great concern. That can be taken care. Yes.
In fact, if you look at the disaster management structure in the country, people in the press or on the ground also, people have started knowing that there is a state disaster management authority, like Delhi Disaster Management Authority and the National Disaster Management Authority. What is required is the activation and visibility of District Disaster Management Authority. This is existing, but it is not visible. So that has to be activated. It's a structure which was created for the purpose of these pandemics and other disasters. Pandemic is a disaster. So District Disaster Management Authority have to be visibly functional. That is the urgent need today. It may not have been the need yesterday or maybe in 2020, but in September 2021, there is an urgent need to activate and visibly push it forward the District Disaster Management Authority, DDMA, not Delhi Disaster Management Authority, but 12 DDMAs in Delhi. Are they visible? Are they holding meetings? Are they taking decisions? Are the decisions being communicated to the community in the district? I don't think that is happening. That is what is required at the moment.
Yeah. Dr. Puneet Chandna has raised his hand.
Yeah, hello, good evening, panelists, and good evening, Dr. Chandrakant. It's a pleasure to have you here. A great, insights into, how we open up and the dynamic questions, and of course, thank you to Dr. Jain for letting us have a real-time video on what the member health and the secretary health were talking about. So I don't know, one would love to have you for minutes, not maybe hours, Dr. Chandrakant. So may I request you that I have a question on the international travel. I have a question on the vaccination. I have a question on maybe the mutants. So I leave it to you and your good self to allow me any one of your choice.
I think you please ask both. I'll be happy to answer.
Is it all right? Great. Thank you very much.
Late, yeah.
So nice of you. I'm obliged. So I would like to start, we are talking about the RT-PCR test for quite some time. Unfortunately, if I see people who are traveling, I have some international patients, because they come to India for a lot of cancer-related work. And my major is in oncology, that too molecular. So we see that, there is an assay called as the enzyme-linked fluorescent assay, which is the IgM serum, to be more specific. That's what is asked by the government for people who want to go back. Why is India not looking if the relevance of the ELFA test is much more better and absolute? So why would we not like to have this? And then follow-on question would be on some vaccinated numbers from UK. So if you could answer this one for us, please.
So you are mute, sir. You have to unmute.
Yeah, no, now I am okay. So I'm not very sure that I know more detail about this particular essay. So I'm in the best position to answer or not. But broadly, what we need to remember that in a public health program, the testing is selected based upon some of the criteria, and RT-PCR is fairly sensitive and specific to identify this test, but also this is fairly widely available. We would not, in a public health program, you do not roll out the test which is available, either very expensive or available in limited area. So my broad sense is that RT-PCR is something globally accepted. The test is widely recognized, so that's why it has been standardized. Of course, India is doing rapid antigen test and some other tests which you are recommending can also be included. But my sense is that I don't know what would be the cost of this and how much infrastructure and facilities are available. So factoring in all of those things, the government might not be doing that. I don't know, honestly, I don't know details about the tests which you are fluorescent assay you are suggesting. So I cannot answer that what is sensitivity, specificity, or why some other countries are doing it. So I stop here on this one.
Right, no problem, sir. Thank you very much. And allow me to quickly get on to my follow-on question. We understand that, I'm not talking about the waves per se, that we are in the second or the third or the fourth, but let's imagine, or it's a common belief that India is looking forward to the third wave. Whereas if we talk about, we have been referencing UK and USA quite a number of times in studies and so on. The recent data which I downloaded from the Asset Publishing website on the UK government website, it has monitored the Delta cases, which is likely to be origin of India, if not a combined origin of, let's say African and Indian put together. So now we are talking about these cases from 1st February to 15th of August. And the data is published as recent as 20th to 25th of August, which has just gone by. We see vaccinated people, who got Delta variants were about 73,000. Unvaccinated was almost more than double, 1,83,000. But when we come to the deaths, which were, within 28 days of the positive specimen rate, we saw that the vaccinated deaths were higher from Delta in UK, which was about 0.9%, when for the unvaccinated was about 0.21%. So is it that the fatality is because of the Delta variant, which a few of us Indians who were traveling have taken it back to the US or UK? Or is it that the vaccines are not really working against the variant, even after the second dose?
Well, so thanks for pointing this data out. After listening to you, what I could infer, and I know broader, not this data, but I know broader data. The key is that the fatality after vaccination is far lower than in comparison of fatality before vaccination. So in all the previous wave had a higher mortality and higher hospitalization than the wave which is happening due to Delta. What we know that the proportion of hospitalization is far smaller than the previous, even though Delta variant is affecting them. Now, coming to the more specific part of your question, that the fatality is higher in vaccinated and less in unvaccinated. The way I can immediately think of the answer probably lies that because you have used data from January, or the data which you have quoted is from January to August 15, 2021. Now, majority of the people because UK started age descending vaccination drive, which essentially means that they started vaccination for 70 plus, then 60 plus, and once they reached on saturation level of vaccination, then they would go to a next level for 50, 40. So it is very much possible that the people where you are looking for a higher mortality, vaccinated people are those who are actually in the higher risk age group. So in comparison to the previous wave, the death might have come down, but those unvaccinated which are being factored in are those who are in a healthier, younger age group, which already have a low risk. So it might be linked to the risk of that population group, because vaccination started as per the higher risk, and then if though their risk in comparison of the previous wave reduce, but its risk remains still high. So that could be the partial answer. Otherwise, wherever the data is available, it clearly points out that hospitalization rate and mortality after vaccination is really low. Rather, there is extensive data available, and only yesterday, Washington Post or one of the the Atlantic posted that data, that majority of nearly 99% of the people who are admitted in hospital right now in the United States are those who are unvaccinated. The contribution of vaccinated people in hospitalization is around 1%. So hospitalization and of course, hospitalization is low, then we can assume that mortality would also be low. So data is very clear from US data that it is pandemic. This is they US use different language, like they have a different style of saying things. They are saying that this is a pandemic of unvaccinated people now. Before it was a pandemic for everyone, but now pandemic of unvaccinated people. So we can be fairly confident that vaccines do protect. UK data, it depends upon how you analyze the data. I was also looking at another set of data from UK where we found that the difference in mortality and hospitalization in less than 50-year-old vaccinated and unvaccinated is almost no difference, while there is a higher difference in more than 50 years. So we need to look at it closely, but there is no doubt that vaccines do reduce hospitalization and mortality, and also against Delta variant, though relatively less. But a final point I would like to put forth is that of course Delta has more immune escape, but the situation in India is very different from UK. UK first did vaccination, and rest of the world first did vaccination, then Delta is affecting them. That's true for US also. India first had a Delta, and now they are doing vaccination. And the outcome here will be very different, because there is a scientific studies and evidence which shows that previously infected individual, if given even a single shot of vaccine, is more likely to have a manifold higher antibody than the both shots, somebody who received both shots of vaccines and never infected.
Right. Thank you very much. But then it's like one final endpoint while you have raised this is we believe that the ACE2 inhibitors are, less in quantity, or maybe the upper airway, immunity in children is much higher than the adults. But given the point that, that the new viruses which are mutating, and especially the new D950N mutation, to be specific, which is different than the P681R, and we are talking about now most of the studies done on the Petri dish, maybe the representation of the cells which were festooned and taken up for the spike protein testing were not so accurately representing the actual virus, and it will be difficult to actually work on the serious viruses like this. Do you think there is a mutation or two still that remains under the fold of the Delta variant, which may cause more problems in the future? Because my hypothesis would be that the HKU1, which is the variant which is usually for the common illness types, and which also has a furin site, but furin site may not be the only site for the spike protein variants or the splicing, whereas the N-terminal also would also be a problem issue. So do you think there are two variants more, or one or two more to come?
Well, so this is another topic to discuss, but quick points. One is that Delta is not more severe for children, because children do not have a sufficiently developed ACE2 receptors. So, and Delta has not changed their behavior, so it remains the same for children. That's one. Second part is that it's not about the Petri dish studies only, but there are studies which are being based upon genomic sequencing data. And then the researcher in other parts of the world, also in India, gone back to the clinical record of the patients, and then they have seen whether this mutation and what were the clinical outcomes. So there is fairly good confidence on that. Final part is very important. So I want to say three things. So this part of Delta evolution or evolution of SARS-CoV-2 has been studied by evolutionary virologists, and there is a study published on 20th of August in Journal Science. Was it Science or Nature? I think it's, yeah, Journal Science. And what they have found, the virologists have said three things. One is that this virus has surprised. The Delta is far more transmissible and infectious than the previous variant. And coronavirus usually do not do that. And those scientists studied coronavirus throughout their life, but this has surprised. But they also say that this virus is, of course, not most transmissible or infectious, as the measles is far more transmissible, threefold. So there is still some scope of more transmissible variant. We cannot rule it out. That's one. Yeah. Second part, they say that at the speed this virus is mutating, in the next 10 years, it could be a very different virus than what we have now. And third part, which scientists are assuming, predicting, that in the future we might need vaccines which would require 2 different strains of virus. So there is much more going on. Maybe we, in subsequent discussion, we can have a separate discussion. Thank you. Maybe we will.
It's a pleasure.
Sharma would like to close this one in another 2-3 minutes or 5 minutes.
Yeah, sure. Thank you.
One last question from Dr. Shiva Ramakrishnan, sir, from Mumbai, sir. Dr. Shiva has raised his hand.
Good evening.
Yeah, good evening, sir.
Thank you to Dr. Chandrakant for the excellent presentation. Now, in US, they have already started booster dosing for all these citizens. Of course, they are starting from the more predisposing factors and all that. Do we require a booster dose? Your opinion?
So the short answer is that as of now, there is not enough scientific evidence to say that we need booster dose. In fact, India is still now in a very good condition that even a single dose, and I've been arguing in my last presentation also, I said that in India, where there was a high rate of transmission of virus, single dose is fairly good protection. Second dose is even better, but we don't need a second dose in India and many parts of the world. And that's what is the second part is that I personally think, and this is what many other people think, that it's morally and ethically wrong that when rest of the world is waiting for their vaccines, we keep administering vaccine with the limited scientific evidence. Third, the origin of this booster dose concept, especially in US, is, in my personal opinion, it's a medicalized healthcare system. They simply think that if they have something, they need to administer to the people, and that's what they are doing. So not enough scientific evidence, and it's even if it's required, like it's unethical in the current world where vaccines are not reaching to the people, and the virus we have seen that unless everybody is protected, no matter how many doses you give, you are still at risk or due to emergence of new variant. So limited scientific evidence, it might be needed in the long run because it's a respiratory virus, coronavirus, but no scientific or ethical or moral, no reason to administer booster dose. Yes, the third dose is something which is scientifically valid, and third dose is different from booster dose. Third dose means like those immunocompromised individual or those individual who are on other long-term therapy, they do not develop sufficient immunity. So to complete primary immunization, they need to be given third dose. But that's a part of primary immunization. Booster dose after a gap of 6 months or longer period is not currently sufficient. There is no sufficient scientific evidence for that.
So booster dose scientifically may be required after some time. With this, I thanks to Dr. Chandrakant Lahariya sir and Dr. Rajiv Kumar Jain sir. Dr. Chandrakant, if you can, to conclude before, you can just put some light on one particular issue, whether staggered arrival, dismissal time, school recess, or participation of children in sports, because once they go to school, they will participate in the break times, they will participate in they will intermix with the other students with So is it a risky proposition, or it?
I think since India is still struggling with the opening of the school, so my suggestion would be that initial focus should be bringing children to the classrooms. Then one thing we need to remember that children or nobody should wear masks when they are involved in running or any physical activity. So open space, some physical activity can be allowed. There is not that much of risk, but it's better to first get the confidence of parents and have children in the school, and then staggered way this physical activity can be started. But as I have been repeatedly saying, there is a limited risk in opening school, and in the life we always do risk and benefit. The benefit of opening school is far greater, risk is limited, and so all the things can be done slowly, and open space without mask is all right, so it should not be any concern.
So
But
the last,
yeah.
yeah, to conclude, we would like to say that yes, the pandemic is still there. Still, it is in a very critical phase. The schools, they need to be open, and the vaccines, we need to give the vaccines because they definitely prevent. And regarding booster dose, time will tell. Science will prevail. And
Dr. Sandeep,
yeah,
there,
yes, sir.
there are two questions in the Q&A box, and now today's attendees, I find two new important public health practitioners who have worked for a long time in Government of India. Dr. Beena Sahani and Dr. Sunil Khapade are present. Let's hear them a little bit.
Yeah,
So that,
Dr.
again,
Chandrakant actually want to leave. He has got some other.
Yeah, that's fine.
Yeah,
But I would like Dr. Beena Sahani and Dr. Sunil Khapade to express their views.
Yeah, so I'll stay to listen to them, but I'll keep my mic off. So thank you very much for this opportunity.
Right, sir. Thank you very much. Please.
Thanks.
Yeah, Dr. Beena Sahani and
Dr. Sunil Khapade.
Okay, sir.
Yeah.
Can you hear me?
Yeah, yeah.
Dr.
Sure.
Khapade.
Yes, sir. We can hear you, sir.
Yeah. Thank you very much for inviting me for this particular seminar, and really it is a very good experience. And I know that school opening is very, very important because most of the children are losing their ability, especially in the language and mathematical, and it was approved. And Premji Foundation has already done a lot of research where they are already found out that there is mental ability as well as mathematical ability is losing, and they are behind 2 years. If they are not going for the school for 1 year, they are behind the learning ability for 2 years, and that is very important. And school opening should be a dynamic process, and it should be start with decentralized system where the epidemiological pattern of that particular area, whether it is okay or not. Chandrakant has covered most of the thing in his skill opening, and was just listener. I just came here for just joining here for the listening the views of you people. Next time we will see that I will be in the panel, and then I will discuss more. But at the same time, their vaccination is not a prerequisite for the opening the school, because children are at a very, very low risk. There is various studies has been conducted in the Europe and America, USA, that the children are 100 to 1800 times lower risk than healthy children are lower risk about 100 times than the others. Other adult population, and that's why we should not consider that schools are the super spreader and all these things, because school, no doubt there are some apprehension in Maharashtra also that if you open the school, the children are not at a risk, but the children can acquire infection by infection, and they will bring their home. But there is also a real chance because the children are only infected, but they don't have symptoms, and they are having low, as you're very well aware that children having not moderate or severe infections are not there. Thank you very much. With this, I am really thankful to Chandrakant and Dr. Jain for this for their presentation, and they are enlightened very highly. Thank you.
Thank you, Dr. Sunil. Definitely, we would like to have you as a panelist in some near future session as the time evolves, because every week we are having our webinar for last 1.5 years, and this is the 67th webinar. And all our sessions, they are live telecasted on the YouTube, and they are available on the YouTube for further reference by all our members across India. So with this, we thank you very much, sir, Dr. Sunil Kharpade, sir. Dr. Beena Sahni, she can unmute. If the panelists have any other question from Dr. Rajiv Kumar Jain, sir. In the meantime, Dr. Beena Sahni would like to join.
There are two questions in the Q&A box. If health also is brought to central.
Dr. I want.
Yeah.
Yeah, Dr. Kamla Fatia, ma'am. Yeah.
Thank you, Dr. for a wonderful session and wonderful presentation. And I wanted little information regarding immunization of children 12 to 17 years, if you can throw some light on that. I think Zydus COVID vaccination is due from October. Will it be starting for children, or any information if you can give us?
Well, it has been licensed, but Government of India will have to take from the public healthcare infrastructure, as Dr. Chandrakant has very rightly mentioned. Children, 12 to 17 age group with comorbidities who have high susceptibility of co-infection and infectious disease spread, they will be number one priority. And in addition, as you know, in our normal pediatric practice also, children with renal disorders, immunodeficiency disorders, they're given additional or the double dose of vaccine. So this practice will be followed for COVID-19 vaccination. But the real hope, which I feel, is the nasal vaccine, which SII is now doing the trial for. The real hope for children, we should consider 12 to 17, if that is the pediatric age group. Only very differential strategy, as Dr. Chandrakant has mentioned, would be, I feel the TAGI will take a view and scientific evidence will go in favor of a selected group of 12 to 17 age group receiving this vaccine, ZyCoV-G, from October onwards. So that should be the strategy, because the priority has to remain for number one, above 60 years, and within 60 years, number one, healthcare workers, number two, frontline workers, number three, all the people below 60 years with comorbidities, and the lower priority, 18 to 60 years. And within 18 to 60 years, 45 plus, number one, higher priority, and less than 45 year, lower priority. That is the way we have to push our resource application on the ground.
Thank you very much, Doctor.
One interesting question which came from Dr. Madhav Kulkarni: if health is also brought to central list exclusively, the practices on uniform policy can be easy and we can move more confidently for pandemic mitigation. Any opinions? Very interesting proposition. Well, the evidence globally shows more decentralized strategy in public health management and disease mitigation, especially epidemic, outbreak, and pandemic mitigation. More effective is the disease control strategy, and more long-term sustainability it builds. So instead of centralization, our effort should be focused on decentralization. Second question, which Dr. Srinivas HK has asked: why is vaccination recommended to be made mandatory for school staff when it's been proved to not reduce transmissibility? Very interesting proposition. Well, Dr. Srinivas, you must understand the goal of vaccinating the school staff is not reducing transmission, but to reduce their having moderate to severe illness and reduce mortality, and also to reduce hospitalization rates. And also, in addition to vaccination, COVID appropriate behavior is equally or rather more important in addition to vaccination. So this is a differential strategy. Vaccination standalone has not significant value. Vaccination along with COVID appropriate behavior for all school staff is very, very important to ensure that school remain open for a longer time, because they shall in further reduce transmission to the children who are attending the school out of their own choice or due to the choice of the parents. And this fact was also stated very emphatically by Dr. Chandrakant Lahariya in his discussion. Thank you for asking the question.
So we have almost spent 2 hours discussing these two important topics, but still many more questions, many more queries from the participants and the panelists, and in my mind also. But considering the time, I would like to conclude this session because it's almost 2 hours, and this debate is an ongoing debate, and we will discuss it next time. We'll call Dr. Karpade also, and Dr. Chandrakant Lahariya also, and many other speakers who can throw some light on how we should proceed. So a lot of insight was given by Dr. Chandrakant and by Dr. Rajiv Kumar Jain. So we thank you very much, and we request you all to subscribe to our NOC DigiConnect webinars channel, where all these videos will be available. So already more than 87 videos are there with interesting topics, and they are of great importance because they are the resource things which you can always refer to, and they are the authentic source of information which you can refer to and take actions in your respective organizations. So with this, sir, thank you very much, Dr. Rajiv Kumar Jain and Dr. Chandrakant Lahariya, for sparing your valuable time, and for all the panelists and all the participants for sparing their valuable time. Thank you very much. We'll meet next.
Thank you so much.
Thank you very much.
Thank you very much.